Hello, hello. Good morning, everyone. We're going to go ahead and get started. We're trying to stick to a tight timeline. We know everyone's anxious to go play golf, go hike, go swim. I hear you guys back there. But anyway, welcome to the head and neck section of our meeting. My name is Riz Aslam. I'm from Tulane in New Orleans. We had a great time seeing you all last year in New Orleans, and it's hard to believe that it's a year later already. But it's good to see everyone and same smiles and happy faces. So without any further ado, I'd like to introduce a dear friend of mine and colleague, Dr. Imad Kandil. Dr. Kandil did his residency at SUNY Downstate in Brooklyn, followed by an endocrine fellowship at Johns Hopkins. He's been a faculty member at Tulane for 2 decades. Sorry, Imad, not trying to date you using decade markers, but it just speaks to his experience. I've had the opportunity to work very closely with him and learn from him many nuances and details and tricks of the trade, as they say, when it comes to endocrine surgery. Imad's published over 500 publications. He's been a dedicated researcher, a clinician, and educator for his entire career. He just recently launched the Kandil Institute of Thyroid and Parathyroid Surgery. The first time I saw robotic thyroid, how many of you have actually seen robotic thyroid surgery? It's probably a good thing. I'm just kidding. So the first time I saw it, I moved from Cincinnati where we were doing MyVats. How many of you know about minimally invasive video assisted thyroidectomy? Probably people about my age or a little bit older. It was interesting, make a little 1.5 centimeter incision, use endoscopes, get in there and move these small thyroid nodules. So I was proud of myself for learning that technique. Then I got to Tulane, and my dear friend to my left was like, hey man, come to the OR, I'm doing a robotic thyroid. And it was very interesting, a little scary for me to see it, but the way Dr. Kandil was able to approach the thyroid gland through an endoscopic approach from the axilla was truly fascinating. He pushed me to learn. I'll just tell you I haven't, but when somebody's a master at something, you let them stay the master sometimes. So Imad has always pushed the envelope and trying to make patients' lives better, whether it's minimally invasive, maximally invasive, whatever it is, whatever they need from a thyroid endocrine surgeon perspective, he would do it. So anyway, I keep going on, and I could rant about a lot of the amazing things that we've done together. But initially, Dr. Kandil was going to speak about the ATA guidelines and an update. Those are readily available. Everyone has AI. You can ask for any updates that you have a question about. But we really wanted to pivot something that would be more important towards your practices. And the new topic for this morning is going to be beyond the adenoma dilemma in reoperative parathyroid surgery, right? You have that patient, they bounce back, what's going on? That's kind of what Imad's going to touch about this morning. So without any further ado, Dr. Kandil, please.
Well, thank you, Riz, for the wonderful introduction. Riz knows that he knows that I like to talk. So before I just came here, it's like, Imad, you need to cut this short, please. Today it's Arizona. He knows that for years that when I keep talking until the person who invites me come and give me a hug. I know it's over, but I'll try my best to avoid that hug. So I will talk about a few points here with the indication, workup, importance for the preoperative localization, and some adjuncts that we use as surgeon for intraop, and novel technologies that I think as a surgeon you should be aware of. I think last year I gave a talk about the remote access approaches. So I took the thyroid and parathyroid out. I've done over 1,000 of these cases from transaxillary, retroauricular, transoral, and still until today, at least a colleague of mine who was a chief at Hopkins, and he started his own institute, and his main practice is focused on the transoral approach, and he only charged cash for this, and there's a good volume for that. Having said that, and after I've done close to 80 publications on this topic, and at the peak I used to do maybe 5 cases a day with robotic cases. I don't really recall the last time I used a robot, and I will tell you why. So I was at Tulane for 2 decades, and I used to enjoy doing these cases and showing videos with ICG and doing robotic cases here, finding an adenoma like this, and it's beautiful. And I have to say though, maybe for the last 10 what was booked at robotic parathyroid, I've done it without the robot. I do the exploration and I take the parathyroid out that way. And this is something that we're gonna touch upon today, what cases that you can really consider doing focal versus multiglandular disease. Again, a case like this, I don't do this anymore, and I'll tell you at the end why. So I started my own thing here, and so far it's 2 centers, maybe 3, but it's just being busy and really, just from the beginning, trying to consider even hiring another surgeon in 1 center, so we'll see. But I don't need to speak to this crowd about where is the missing parathyroid, but this is here a standard table for the missing upper gland and the missing lower gland. But in general, I can tell you from experience that the most common location for the missing upper gland is the paraesophageal retropharyngeal one. It's extremely common that this is usually missed. And if you just spend a little time and just go behind the pharynx, you'll find this missed gland. And the most common missing lower gland is usually in the thymus. And you should be always consenting the patient for possible thymectomy when you do a parathyroid surgery, because it could be just in the thymus, and that's what you need to do. So the very important topic that there is also supernumerary parathyroid gland that can be present up to 15% of the cases, and usually these on the thymus. And this is if you treat an MEM patient, you just need to do a routine thymectomy. So these are important facts. The double adenoma can exist in up to 15%. And honestly, if I see a double adenoma, I would worry about the hyperplasia and treat this as a hyperplasia more often. And this multiglandular disease is going up, started to be at 10%, is going up to 25%. And I can tell you now, with endocrinologists are trying to diagnose more and more of these. So in my practice, I do mostly hyperplasia. I don't see a lot of the localized disease, and if I see it, I will show you what I do nowadays for these. Success rate is reported, this is with the high experience, is a lot lower than a single adenoma. So you need to be humble. No matter how good you are, every time when I think I got this, I get humbled. So it's a very fun disease to treat, but it's always a humbling disease. And you need to know that at some point when reoperation, the key is not to jump. And we're going to talk about this today. I'm going to make it like a 10-point thing with David Letterman thing. But you don't want to go back blind and a scarred neck and thinking you're a great surgeon, you're going to find things. So there are 10 questions that I'd like to answer before going for re-op surgery. First, is it really a true diagnosis? So let's talk about this, because really as a surgeon, you need to understand this very well, because as I said, a lot of what I see is the uncommon presentation, which is normal calcemic primary hyperparathyroidism or normal hormonal primary hyperparathyroidism. And that can be present in 20% of patients. So we all know for primary hyperparathyroidism, you will have a high calcium, high PTH. The normal physiology is if you have high calcium for any reason, the PTH should be significantly lower, suppressed, and vice versa. But if both are elevated, that's classical primary hyperparathyroidism. So I cannot tell you how many times over the years I had a patient showing up to my clinic with hypercalcemia for parathyroid surgery, but their PTH is low. There's something else going on. The most common cause is a secondary malignancy, multiple myeloma. I diagnose patients with cholangiocarcinoma. You don't want to operate on a patient with a calcium of 11 and PTH of 8. If the PTH is suppressed, this is not primary hyperparathyroidism, it's significantly suppressed. You don't want to touch this patient. You want to really figure out what's the problem. So you will have a secondary malignancy that's causing this, and you want to check on these patients PTH-RP. We always talk about this benign familial hypocalciuric hypercalcemia. It's extremely rare, but it's just overrated, but it's something that you can look at when you check the urine calcium too. I'm going to give here a few examples. Same patient, we're going to change numbers to just understand the diagnosis, and I think it's very important. So now we have this young patient here who had gastric bypass. I was involved recently with a case similar to this, where the patient underwent, in my opinion, unnecessary operation. I was actually trying to defend the physician, and the patient had a complication. So the PTH in these patients expected to be low because they have vitamin D deficiency after the gastric bypass surgery. The calcium is 7.7 in this case. And this is a secondary hyperparathyroidism. You treat this by vitamin D supplementation, not by neck exploration. Just yesterday, I had a nurse practitioner in my office referred for parathyroid surgery because her PTH is high, but her calcium was not that low. The maximum is like around 9.1, 9.2. You are not gonna help this patient. If a calcium is that low, it's not gonna be a parathyroid disease that you need to do a neck exploration. And she comes in with the scan that shows possible hyperactivity on the system-EB scan. It was correlated to a nodule that requires a biopsy. So you gotta be careful with this and avoid unnecessary operations. So you're not helping this patient with this. So if we change only here the number of calcium to 10.6, yes, that's primary hyperparathyroidism, classical. You diagnose this as primary hyperparathyroidism and vitamin D deficiency. Just before the presentation, we were talking to an expert here that does a lot of parathyroid surgery, and he's saying that it's very frustrating. You do a good surgery, PTH drops in the OR, then the patient comes back with elevated PTH. Guess what's the reported rate of this? 20%, 1 out of 5. After good successful operation, you actually cured the patient. The patient will come to your office with elevated PTH, and that's because of their preoperative vitamin D is low. But their calcium is normal now. And even endocrinologists sometimes are not aware of this. They send them back to you, it's like the PTH is still elevated. Well, the calcium is not elevated anymore. The calcium was 11, now is 9.5. This patient is cured. Now this patient needs a vitamin D supplementation. There's actually some good research on this that you can give vitamin D right before the surgery. With planning for the operation, you can avoid that. So I check the vitamin D, I schedule the surgery, I start them on vitamin D before the surgery to avoid this dilemma and headache. And there's good data that this will help. What you don't want to do though, and Silverberg from New York years ago wrote papers on this. If you actually give this patient vitamin D without surgery, you increase the risk of complication, nephrolithiasis, all kind of complications, because of the vitamin D will help the calcium absorption, and the calcium will go high and complication will be high. So this is very important. So you don't do it except with the planning for surgery and right before the operation, not as a treatment. So if we change things, keep the calcium at high, but the PTH is upper normal, what is this? This is normal hormonal primary hyperparathyroidism. You operate on this. This is a surgical patient, and most probably it's a multiglandular disease. And you need to know this as a surgeon because you don't want to really worry too much about a glandular. And this patient, 100% four-gland exploration, no focal exploration. Because once the PTH is in the upper normal, 100%, most probably multiglandular disease, very rarely, extremely rare to deal with a single adenoma. How about if the PTH is mildly elevated, like here, 95, and the calcium is 10? This also is primary hyperparathyroidism, but it's a normal calcemic variant. So to repeat, this has happened in 20% of patients nowadays, that's what we see. And the rate is higher in America compared to the rest of the world because the rest of the world still, by the way, you know, in the rest of the world, they don't do calcium routinely as a part of the basic metabolic panel. And a lot of these patients get diagnosed because they get admitted for obtundance, whatever problems related to the high calcium, then they get checked, then they find a single adenoma. But in US, it's a routine, so they do all the workup. But this is a patient that would benefit, again, from a parathyroid exploration. So knowing all this is very important. So in a case like this, when you have a calcium of 14 and the PTH is high, this is, you will need to worry about cancer. Anything above 14 and a very high PTH with a normal kidney function, this is, you need to plan en bloc resection, consider central lymph node, and really do good workup for the evaluation of the vocal cords and planning to preserve or resect have a good counseling. Because Mayo Clinic data showed 50% nerve injury from parathyroid cancer. The guidelines of the ES does not recommend routine central lymph node dissection in cancer, but I'll show you a case that guidelines are guidelines, and you just need to worry about clinical presentation. So diagnosis. So what's a number 9 question? Is the patient symptomatic or no? So I can tell you, I wrote many papers on this, multiple analysis. I think everybody with the disease 100% needs surgery. Everybody is symptomatic, they know it or they don't. You look at the data, this is here surveys on over 20,000 patients, and they split the calcium between 10 and 11, less than 11, more than 11, and you can see here there is no difference between lower than 11 or higher than 11. So the calcium levels does not correlate with the symptoms. I can see a patient with 14 milligram per deciliter, very high calcium, no symptoms. They think they have no symptoms, but the data showed that they do much better afterwards. And this is what shows that even if they think they are asymptomatic, the symptoms completely resolve after surgery. So anytime you go to the American Association of Medical Surgery, you see benefits of surgery, spine, hip, bone density improvement. The bone density can improve within a year or two, reduce rate of nephrolithiasis, neurocognitive elements, decreased need for Viagra, all the good stuff. So a lot of research on this. The thing is, it's just a magical operation, and everybody will benefit. So symptoms is not a big thing. I can tell you everyone has symptoms, and this is not the issue. Second thing, when you have a plan to do a redo operation, you need to learn everything about the first surgery. You need to find the operative report, see exactly what was done. Was it bilateral expiration, unilateral? What's the pathology? And honestly, experience does matter. It's not just imaging. And it's important because I can tell you this, you need to know who did the operation. If the patient, for example, had surgery by an inexperienced surgeon, you can feel confident going in. Versus if they had a surgery by an experienced surgeon, you need to take it easy and don't do workup and repeat the workup every at least 6 months to a year and slow down before going in. How about patients with secondary and tertiary hyperparathyroidism? So if you look, the ES tried to put some guidelines for what's the best operation for this disease, secondary or tertiary. We know that there are 2 operations. Either you do subtotal parathyroidectomy, 3 or 3.5 glands, or you do a total with autotransplantation, take all. And the consensus of this, that there was no, it cannot be done, we cannot really give any recommendation. But what we did actually a study here. But first, what's a tertiary hyperparathyroidism? Tertiary hyperparathyroidism is not only on dialysis, on transplant patient with a high calcium. You can have this diagnosed in dialysis patients. So any dialysis patient who starts to have high calcium, 10 milligram or more, this is by definition a tertiary hyperparathyroidism that requires a surgical intervention and should not be treated by medical therapy anymore. Let's be honest, you're gonna wait for the referral by the doctor. We're not the one who make the diagnosis or the referral. So which operation is better? And honestly, there is no consensus here. And I had nephrologists that stopped referring to me because I don't do the approach that they like. They want to be more aggressive. I was trying to figure things out, and I was trying to make sense of what I do. So I end up doing a study with the, this is the ES, and they basically said, we don't have any consensus, we don't have any data, which one is better. So I decided to do a multi-institution study, and it's easier to do it with my Asian friends. I have a lot of friends in Asia. We did it with Korea. We did the largest published series on this, and we looked at which operation is better. To summarize, if you do more, you have a higher success rate, but you have a higher complication. If you do less, lower success rate, but lower complications. So hypoparathyroidism was higher if you do take the whole thing out and do autotransplantation. And the bottom line is what we concluded, that really you have a higher cure rate with the total parathyroidectomy or transplantation, but higher rate of hypoparathyroidism. It's not my favorite operation anymore in transplant patients. It's very hard to hurt a dialysis patient with more parathyroid surgery, but you really can hurt a transplant patient. In experience, I don't do this anymore. Aggressive surgery, total with autotransplantation, and transplant patient, because now they have a normal kidney function. You can really hurt them, and they can really have significant issue with admission, multiple admissions, etc. Dialysis patient can tolerate a very low calcium, at 6 milligram per deciliter, with no symptoms. And these patients can go home with that very low level, no problems. A normal patient with a normal kidney function, they can have a calcium of 8 and have tetany. 6, they are not going to be surviving, actually. But dialysis patient, 6 milligram per deciliter, no symptoms. It's just amazing. So you can't really hurt the secondary versus tertiary. So it's important to have that differentiation. So how about going back to the OR? You need to read the path report. You need to see how many glands removed. And again, everyone loves to see these big adenomas, but this is not the usual anymore. I love this paper. It's an old paper, but it's true that single adenoma decreased over time. We are diagnosing the disease early, so we don't see the big ones very often. Microadenoma are more common. And if you see microadenoma and in one gland that you need to, if you see like an adenoma that's not very impressive, then you need to worry about multiglandular disease and do more of exploration. And if you have your first gland as less than 200, so I do frozen section everything, and I want to know the weight, but I 100% agree with this. If your gland is not very big, less than 200, then most probably you're dealing with multiglandular disease, and you need to do not just depend on your PTH level in the OR, and I'll show you data on that. And you need to do more of multiglandular exploration. This is just an example, no names, nothing, but I had one surgeon that used to do a lot of parathyroid surgery, and I felt very comfortable going after him every time without any localizing studies. The reason I show this here, because he used to biopsy every parathyroid to prove that it's normal. The pathologist tell him it's normal, so he leaves it alone. Well, it's hyperplastic disease. So it's a clinical diagnosis. It's not an imaging. You do the imaging studies and all this for roadmap, but it's biochemical diagnosis. So he goes in, you can see here, he found all glands, he biopsied them all, and it's benign, and he told the patient he can't find it. He's a safe surgeon. I go in, what do? I remove 3 glands, and patient is cured. So, but I know what I'm doing. I know this guy, he does this all the time. I'm successful after him. I feel comfortable. I'm not waiting for positive studies. So I be careful with that. So the question now, should we do a targeted or subtotal? So I like the study from Cleveland Clinic. They looked at the intraoperative PTH on these patients, and they looked at scans, positive systemicity, ultrasound, etc. And again, multiglandular disease was not predicted by these as good, and more importantly, only 22% of patients with multiglandular disease were detected by persistently elevated PTH. Like, it's not common. How many times you leave the OR, think you got it, everything is good, the patient comes back to you with a high PTH and calcium, is like, what did I do? It dropped in the OR. You did not do a 4-gland exploration and you missed it. And it's harder now to go back. I said it's humbling. It happened to me. Like, I feel like PTH dropped, it's perfect, I'm good, I'm done, and patient comes back with calcium. I rushed it. And that's why, for these reasons, I started to be a big fan of multiglandular disease, except in certain cases. A very famous paper from the Norman group from Tampa showing the difference between bilateral and unilateral, and they routinely do bilateral exploration every single case, showing a significant improvement. If you do a lot of parathyroid surgery, this 5-6% difference is humongous. And you always remember these patients that failed, and it's not fun to treat. So they routinely do bilateral. And most endocrine surgeons, in my opinion, do a lot of bilateral at this point. So if you have a patient who had prior surgery, before you go in, you gotta really make sure that you cannot depend on the voice, as you all know, and if they're hoarse or not, because it's important to do the vocal cord exam, right vocal cord high risk, etc., because of possibly non-recurrent disease. And just symptomatic assistance, unreliable, multiple research on this, and I don't need to speak to this crowd about that. But good evaluation of the vocal cord is important before going back. Before going back, you slow down. Like, I don't slow down with the negative scans. As I said, it's biochemical disease. You go ahead and explore first time. Second time, I slow down. I do all kinds of scans. I might keep repeating it. you need to develop this trust with the patient. It might not show in a year or two, might show up later, but you want to make sure when you go in, you cure that patient. And we all know about all possible tests that can be done, and I started to tend to do routinely a lot more than what I used to do to make sure I'm not missing anything. Even if I do my routine ultrasound, what I'm showing something here. So I think if you have everything negative and you do have a positive something in the chest, that could happen. It's less than 1%. You do it once in a while. I'm just showing here that this is on the heart. You do it with this. You do not refer the patient to the CT surgeon. You go there with them. They're really not sure what they're looking at, and you want to be with them. They are not sure how that thing looks like, the parathyroid. I'm just showing here a sternotomy case where we opened and we found it on the heart, and you just take it out, and you do also the gamma probe afterwards to confirm activity, and they're not removing just a little fat. And nowadays, and then we move to the, and then again, that's what's considered partial sternotomy. And then there's another one, the chest here, very low. You can do it with VATS. You can use sometimes the gamma probe, go around it, find it, and then you take it out and you confirm the activity outside. You always do a frozen section. And in every single case, you'd be surprised that really the thoracic surgeon need your help. They are not sure what they're looking at. Like, what do you want me to take out here? So you're gonna be with them, and it's a combined approach to do these cases. And now we can do this with the robot too, as we talked before. The ES recommend routine ultrasound, and actually if you do a good ultrasound, you can find these, and this nice because you can adjust your skin incision and don't make the incision very long. It's hypoechoic lesion that you can localize. It can have, most of the time, a pooler blood supply that you, if you decide to do something called ablation, that I can talk about later, to get that pooler blood supply, that's the most important thing to devascularize this gland. How about parathyroid cysts? It's not uncommon to see this, but I can tell you this is non-functional usually. This is not a disease of primary hypera. If you see a parathyroid cyst, this is not the thing that's gonna cure the patient. Parathyroid cyst is usually not functional. This is a patient who had the thyroidectomy, lobectomy. So the scan was positive there. The surgeon went in, could not find it, retropharyngeal, did a lobectomy because can't find it, but still is missing there. One time a surgeon called me from the operating room, cannot find it, and so I said, just find the esophagus, go behind it. He found it. It's usually, it takes a little time. The first time you do it, you're gonna do it every single time, but these are the most common missed ones. We will talk about MRI. 4D CT scan, I think is important and it's good. 4D CT is very good. MRI, a lot of research on it, but it depends on your institution, but 4D CT scan is more accurate. PET scan, if you do it, believe it or not, PET scan is the standard of care in Europe and in Canada. It's like each one gets a PET scan for parathyroid. We don't do this in America. We cannot get approval for this, but it can be actually a much sensitive thing. The toughest parathyroid cases when you have an inflamed thyroid, like Hashimoto thyroiditis, because they have extensive lymphadenopathy and it's just a misery, specifically if the patient has a multiglandular disease. I know, I see someone laughing, he knows a lot about this. It's a misery. You don't know where's the lymph node, where's the parathyroid. It's just, it's fun, but you need to be prepared. The gland is very inflamed. You can diagnose this with ultrasound, even if they have no antibodies. Graves' disease, the same thing. But here's nice, beautiful cases with parathyroid adenoma. You can see it, hypoechoic. The more you do this, you're gonna enjoy doing it and have fun. And you show it to the patient, and you can do this. I used to do this with the robot, not anymore. This is a nice adenoma here, esophagus, tracheoesophageal groove. And this can be done really through an incision, hidden, or with the next thing, the ablation. Another one here, intrathyroidal, can be present. I don't know, I do a lot of redos, so I see a lot of intrathyroidal parathyroids. The surgeon go in, remove a bunch of normal parathyroids, and the parathyroid's there. So let me give you an example here. Classical case, young female patient, primary hyperthyroidism. She goes for gland exploration. He goes to the side that is positive, end up removing 2 normal glands. Patient has persistent disease. You find the lesion, it's right there, it's intrathyroidal. You take it out. Well, how do you diagnose it? Before you operate, you do something called the PTH washout. You put a needle in, and you send the aspirate with a little saline, just 1 cc of saline or something, for parathyroid hormone level. And if it comes high like this one, 5,000 something, then you know that this is a parathyroid. So in this case, this was years ago, over a decade ago, you take it, you do a lobectomy. The standard of care is to do a lobectomy, and the intrathyroid, the parathyroid there, and that's what you have. Well, let me show you this case though. It's a couple of years ago. Another patient underwent parathyroid surgery, removed normal parathyroid. She has this lesion in the thyroid. I do a PTH washout, it's elevated. I took her to the OR, I placed a needle there and did radiofrequency ablation. I performed intraoperative PTH, and within 10 minutes, so this is how it takes literally a few seconds to ablate this, and the PTH dropped from 270 to 39 intra-op, and she remained eukalcemic. I did not take her thyroid out. Remember, if you take the thyroid out, you keep these patients, you can make them hypothyroid and all the kind of things. And that's a real issue now. That's another discussion. And you can do a perfect operation, but guess what? The word out there, they know about all the research, about 90% of patients after good successful thyroid surgery, they might never feel normal again, brain fog, thyroid fatigue, all this. A lot of patients with good, perfect operations, 0 complication will complain from the scar tissue, neck discomfort, dysphagia. Look at the survey of patients. You got 0 complication, but patients are complaining, and patients are aware of this, and no one wants to be on medications anymore. So something to consider. When you have a case like this, when the parathyroid and the side of the thyroid, sometimes you really cannot tell if it's inside the thyroid or separate. And I tell the patient at this point, I'm going to go in. If I'm able to find the plane easily, I'll do that and I preserve your thyroid. But if it's in block, you cannot cut across the parathyroid. You want to avoid the parathyromatosis, which is a disaster. In many cases, you go in with parathyromatosis, you remove 9 parathyroids. This is not supernumerary. The patient had some parathyroid surgery and they fractured parathyroid there before, and these just keep growing to multiple ones. And it's tough cases to manage. So when you see one like this, is it inside the thyroid or is separate and pushing the capsule? You cannot figure this out with any scan. You only can figure it out intra-op, but you prepare the patient for possible in-block resection if this is intrathyroidal. So let's watch this video, and I want you to let me know if you think, what is this? Are these thyroid nodules or parathyroids? I'll run the video one more time. Trachea, carotid. You can see this lesion here. There's another lesion right here. It's on the thyroid. I'll run it for the 3rd time. One here, it's inside. So, can I have a show of hand if you think these are thyroid nodules? Okay, well, this is not uncommon. Radiologists can read as possible thyroid nodules, and they can biopsy it, and guess what? Usually the biopsy can come back as a thyroid nodule, benign nodule. You know why? Because they put the needle through the thyroid, so they core thyroid tissue in their way. And if I'm worried about parathyroid, I send the wash out. And my pathologist, Sudo, actually the pathologist at Cleveland Clinic, I know this from my other colleagues, they wait for the PTH washout before they call it. It's very hard and difficult to read parathyroid on cytology. You can have some similarities. You always have thyroid tissue in your way. But this is a typical case of secondary hyperthyroidism in dialysis patient. And ultrasound is a key here. So you don't want to biopsy these. It's hyperplasia. All these are nice, large parathyroid gland in secondary hyperplasia. But this is a case with persistent disease. So let's talk about the large calcium. So if you have a high calcium, high PTH, like this patient, positive scan, and you see here there is some invasion with going into the muscle too. So the standard of care with the guidelines that you should just consider in-block resection, no central lymph node dissection. But in my ultrasound, I see these rounded lymph nodes. So rounded lymph nodes mean these are metastatic, and they are very suspicious. So I perform on her a central lymph node dissection, and you can see in 2 out of 7 lymph nodes they have metastatic disease. And that's another case with a big mass. You need to be prepared, as I mentioned before, for nerve resection and nerve reconstruction. This is when I called Dr. Aslam. He did help me with many of these cases where he does his microscopic reconstruction for these. Because a lot of times the patient can have a good vocal cord exam, but when you go in, the mass is completely encasing this, and that can happen in thyroid cancer too. The mass will be clinically encasing you see the nerve up and down, but the whole thing is encased. So you gotta resect it, otherwise you are not helping this patient. When you treat these patients with parathyroid disease, redo or not, you always need to look at thyroid nodules and work this up, and you need to understand here that 57% will have concomitant thyroid nodules, we know that, but 1/3 of these will have cancer. So it's important to do this. I would never forget my mentor, who's the chief of endocrine at Hopkins, Paul Livingston. He said his neighbor underwent thyroid surgery, but they missed the cancer in it, and it's like I felt so bad that I did not worry about that. How about the PTH washout, the selective venous sampling? So the multiple studies we published like this that on the PTH washout is extremely accurate. It's more accurate than cytology. Let me show you here how you do it. This is a video that we've done maybe 15 years ago. Ramsey is the chief of pulmonary now at Tulane. But this is the needle that we did the biopsy. You take a little saline. This is what's a wash out. You put it here in the needle. So you do this for anything like a PTH for calcitonin, if you worry about mediothyroid cancer in a lymph node or a nodule, and you do it that way. And you know, the guidelines actually say you should not do it unless it's, so we do not do this routinely. You do not do this if you find a parathyroid. I mentioned you only do it if you have intrathyroidal one before taking the thyroid out and make the patient maybe hypothyroid. You want to make sure that this is a parathyroid. Or in a case that you're not sure, redo case, if this is a lymph node or not, you don't want to just take the patient for redo surgery. Redo surgery in the best hand can increase the risk of complication and the nerve injury significantly, from less than 1% to easily over 5% and a lot more. How about what people talk about selective venous sampling? If you look at the data, there's some data, many data show that it's not useful. Some others said it can be helpful, but it's not recommended by the guidelines. But there's no much research. We did our meta-analysis, looked at the data, and showed that sensitivity and specificity are really low. And our conclusion that it's not really recommended, and it's very invasive and does not favor, it's not very helpful as people think to do the selective venous sampling thing. So the final question is, should I go ahead, do a thyroidectomy, thymectomy, or transplantation? The bottom line is you don't want to, these patients have high risk of complication. You want to really become friends with them and develop a trust and discuss all these options and have appropriate consent and talk about all these issues. Specifically, you need to understand that many patients will have multiple parathyroids removed than normal. Now you're dealing with a final one. What do you do here? Or transplantation sounds a great idea, but guess what? 50% might work and 50% might not work. We all think about cryopreservation, but most institutions who tried that stopped it because it's not cost effective and most places do not offer it. And as much as you want to help this patient, you want to avoid the disaster of permanent hypoparathyroidism that increase risk of mortality too. Like you don't want to, I would rather fail in a parathyroid surgery than make someone hypopara. If I fail, they're okay. It's okay. Failure is acceptable, no problem. You make someone hypopara, you actually increase the risk of mortality, the risk of complications, and all this. Permanent hypoparathyroidism is a diagnosis that you make after 6 months after surgery when the PTH is extremely low. Intraoperative PTH guidelines, there are different criteria. The most accepted one, you want to have it in primary hypopara 50% or more into the normal level. 50%, just 50% most probably increasing the risk of missing multiglandular disease, but it needs to be into the normal level. For secondary or tertiary, you want it to be 80%. Again, there's no consensus on this, but if it's less than 80%, then most probably you are not curing this patient. Let's go through some cases. 80-year-old patient, primary hyperparathyroidism, high calcium, high PTH, primary hyperparathyroidism for sure. Multiple medical problems. I see a very localized, nice adenoma here, localized on the scans. I decided not to do surgery. I used this technology here with non-thermal ablation, just a needle stick. The mass did not disappear, shrunk 90%, but she's not here to shrink that little something, but for the normalization. So we've done a good number of these, and success rate is close to 100. And I can tell, like, there's one patient that recently I did, and I told my nurse practitioner he's not going to get cured. I was not able to get my needle in it well, did not work. But you deal with the same thing, that the calcium. I just saw a patient that I ablated her a couple of weeks ago. Her calcium is normal, PTH is still elevated, but the vitamin D is low. You give her vitamin D, should be fine and should be good. So I stopped doing all these beautiful approaches, and I'm doing ablations. So I'm thankful for my academic career to learn more about this, but I'm doing more of this. And believe it or not, nobody wants a cut on this beautiful thing. Dr. Aslam told me not to talk about ablations, but I can't. I'm sorry, Rez. It's just, so I booked over 50 cases this month, and guess how many open out of these 50? 3. Everything else is ablation. Maybe next year, Riz might invite me to talk about this. I think you need to know about it, because I tell you something. Patients do not respect their doctors who are not aware of anything about ablation. You can't close your eye about this. This is a real thing. It works. And there's a CBT code for it. So with reoperative surgery, I learned to be humble, and I just understand that multiglandular disease is a real thing. I slow down, I repeat imaging, and I take it easy, and I can't thank you enough for listening to me and for the opportunity.
Thank you, Dr. Kandil. And if you were wondering, that case where he showed the benign sampling of the parathyroids, and he always confident that he follows a surgeon, he's going to definitely find the parathyroid, it's not me. Thank God. But anyway, thank you, Dr. Kandil. If you guys have any questions for Dr. Kandil, he'll be around afterwards. So in the interest of time, we're just going to push forward a little bit. We are going to change the order of the next two presentations. We'll do the panel last, actually. So, the next talk is going to be by Dr. Samer El-Khodary. Samer, do you want to come up? Samer is the chief of head and neck oncology and reconstructive surgery at Rush University in Chicago, Illinois. He's associate professor there. He did his training at Henry Ford, followed by his fellowship at Cleveland Clinic. And today, Samer is going to be talking to us about changing dynamics in head and neck oncology and management, both surgical and non-surgical. So, Samer, go ahead.
Good afternoon. Thank you, Dr. Aslam, for the invitation and this opportunity. Thank you, Dr. Kandil, for presenting that. It's definitely parathyroid disease, a very humbling disease, and to see someone kind of taking it further, educating us all. I was taking pictures of your slides, even though I do frequent parathyroid surgery, so thank you. I do the presenter view thing. closed captions, is that what that is? Perfect, okay. All right, well, I, manage head and neck cancer, a lot of mucosal cancers. So I'm gonna talk to you about something a little different. These are my financial disclosures, and really, I'm a surgeon. I'm not a medical oncologist, and I'm not an immunologist. So, but I want to try to update you on some of the things that have been happening. And then my life disclosures is that I really feel like it's an honor to treat patients with head and neck cancer. I have 3 little girls, and they call the shots, and then I'm addicted to golf, as Dr. Eslam knows. So we're going to talk about the advances. We're going to talk about some immunotherapy, some modern disease monitoring strategies that you guys should all be aware of, and then demonstrate some of this. So we're going to talk about oral cavity cancer, laryngeal cancer, everything advanced, because that's where the field, I like to think of head and neck cancer, the way I saw it treated as a resident is a different world. I mean, tonsil cancer patients were getting upfront G-tubes and trachs and just never considered for surgery. Larynx cancer patients would walk in the door, get a trach, get a G-tube. It's just not the way that it happens now, and that's how it should be, right? I always tell my residents, if you're doing it the same way you did it last year, you're probably not doing it well. And if you're doing it the same way you did it 5 years ago, then you're definitely not doing it well. And that's really the pace of advancement in all our fields, all our subspecialties, right? I don't treat nasal surgery. I don't even know what you guys do nowadays. So it's pretty impressive. I was learning a lot this weekend, asking a lot of you clinically, how do you do this, how do you do that, just for my own kind of understanding. All right, so we're going to start with this case. 52-year-old gentleman walks into me, second opinion. He's had a neck cyst for months. He's had no real workup. This is my FNA picture. Had this purulence on the first time, and I was the second person to FNA it. And so once that came back, atypical cells, a lot of uncertainty, I basically took that punch biopsy, and I noted this very small ulcer in his tongue. But what you also know is his whole tongue is leukoplakia. He used betel nuts. He has trismus. It's actually hard to look in his mouth. I use a scope. So you really got to do your due diligence. It's not a quick, let me just look in your mouth. I said, okay, let me biopsy that, and it came back as squamous cell. So there's a 2-month delay from presentation to me to actually make a diagnosis, and I'm the, trained, this is what I do. That's the CT scan, FNA'd multiple times. So for this patient, what I did 6 months ago is we said, you know what? You have multiple nodes. You have advanced head and neck cancer. This is not a small tongue cancer. So we got the diagnosis. We got the PET scan. We proved multiple nodes. This is advanced. The patient was very hesitant, what to do. I said, I kind of introduced this idea as a surgeon. Hey, we need to look at this immunotherapy option for your case. Presented him at tumor board, and this patient received 2 cycles of immunotherapy before I would do what I normally do, which is surgery. And this is what happened. This is the CT scan. This node really shrunk down. This is a submandibular gland. Right under it is a small node. This is the PET scan that happened at a diagnosis. This is the CT. It kind of became one node. He's like, Doc, I feel better. I was just like praying on the sidelines, hope I guided him right to do this. And so this is his tumor. This is the area I biopsied. It kind of changed with immunotherapy, kind of hoping that's all positive. And then I took him to the OR. So the timeline now is 2-ish months. It's a long time to know you have cancer. But this is him in the OR. The trismus was real, even with paralysis. This is the best I could do. And that's what I took out. And it was not easy. You can do a partial glossectomy very quickly, but in a patient with trismus, it's an undertaking, right? And we do bilateral neck dissection because of the advanced nodal disease and tumor board discussion. And this is what I took out. It only had 0.2 millimeters, not 0.2 centimeters. Like I called the pathologist, like, are you sure you got this right? He's like, yeah, it's very minimal. Negative PNI, this is the depth they measure. Once again, I questioned this measurement. And then therapy-associated changes, 1 out of 69 lymph nodes. That's his tongue healing because we just did some Alloderm. So I was pretty happy with this because I feel like it downstaged him in a way. He still had to go through radiation and no chemo and continue on with immunotherapy. So why immunotherapy? The reason is when you treat, just like Dr. Kendall was showing you with parathyroid surgery, when you treat a high volume, when you look at it over time, you actually see your failures. You see your patients come back. And same thing with oral cavity cancer, right? I see my patients all the time. I'm very involved and I keep in touch and we review. And you see patients recur. Hey, this patient recurred locally. This patient recurred regionally. This patient recurred in the lungs, right? But so if you don't follow them, you're not going to see it because it doesn't happen right away. It happens a few years later. So our outcomes have plateaued. So we got to be doing something better. So this is the option. The immune system is more powerful than anything you think you could do with a knife and whatever fancy equipment. It's amazing. That's what these drugs are working. So if you can prime the immune system, this is something you'll see. I'll kind of show you. And now we have some evidence. So before you're operating on a whim, I'm going to give you guys a quick story. So I remember when I was in practice, a couple years in, there was this patient. The residents were like, hey, this guy has recurrence. The oncologist was like, can you operate? And it was not resectable. And he was a very high-profile guy, and he had told me, he's like, look, I want to go to New York. There's this new drug. I want to get this drug. And he was like open wound. I mean, it was a very dire situation. And in my mind, I was like, what is he talking about? I kind of feel bad for him. He has a false, I'm just going to, but like, this is a dying patient, and I just want to kind of help him, empathetic. So we tried. It did not happen. He never got well enough to get there. He actually, to be honest with you, suffered probably one of the more miserable ways. I mean, I saw like myiasis, which is maggots. And so he passed away after some time. We did try to palliate him and help him. But that was before immunotherapy was on the agenda, and that's what he was asking for. And truly, though, it ended up getting approved, So I always kind of think about that. So what's happening? So how does it work? Tumors try to hide, and immunotherapy basically doesn't let them hide anymore, okay? So there's two agents you'll hear about. One of them is going to be pembrolizumab. The other one is going to be nivolumab. They all have different indications. These two have similar overall methods of working. So this is a plug. Dr. Aslam's going to appreciate this, but I've been using AI, and I encourage a lot of people that I've been talking to over the meeting just to kind of work with it. So AI put together this little diagram. It's not the best, but it just did it with quickly while I was doing something else. So T cell and a tumor. T cells attack tumors. The T cell looks at the PD-1. The tumors use PD-L1 ligand, and they kind of hide. So what does immunotherapy do? It just blocks that, okay? And what it does is it allows the immune system to attack the cancers. And why does it work in head and neck? Why does it work in a lot of different cancers? Like you're hearing a lot about it in lung cancer, because usually these are highly mutated tumors. We think it's smoking, drinking, and all these things that are happening. So head and neck is actually a really good target for this. The head and neck is a very immune area, right? Your tonsils. HPV is kind of interesting in terms of immune system interactions, and PD-L1 is commonly expressed in our head and neck sites. And so we know that immunotherapy can be used after treatment, but there's something special when you give it to a patient or first. So here's a diagram. This patient diagnosed with cancer, given immunotherapy. You just block that interaction we talked about, and then the immune system is activated. And then you operate on them. And then now, afterwards, you got these memory T cells that come out, and they're killing anything that's microscopic, that we can't even test for. And this is like a different level of attacking cancer, in my opinion, right? And so that's why it's kind of special. You can do it afterwards, but there's something special if you can do it up front. Now you see why I told you I'm not an immunologist, I'm not an oncologist, because I'm a surgeon. I'm getting a little bit out there, but I think it's important for us as surgeons, right, fellow surgeons, to understand what's happening. And really, this is for a lot of our cancer patients. So you should be aware, right? You don't have to like explain it all that much, but you should understand why it's a benefit, and you should have it considered at least. Now, this is not without issues. There's a lot of weird complications that happen. Any organ can be impacted by this treatment. So it's not like, oh, it's just wonderful. No, there's a very high complications and temporary risks, and so you have to be aware. I've seen some, and I'll show you some. So the bottom line is these drugs don't kill cancer. That's what, it's different than chemo. They let your immune system do everything. It allows it. They take the brakes off the immune system. Okay. A couple terms, when you see IO, it's immuno-oncology. It's kind of used for immunotherapy. So that's what that means. You'll see that. And this is the trial. This is a clinical trial in New England Journal of Medicine. We don't get this kind of stuff too much for head and neck, right? These patients got immunotherapy up front. They had to have particular, when you get a test, pathology, they had to have certain testing to be positive. Then they got immunotherapy. There was 2 arms. This is event-free survival. Okay, that's a pretty significant. We don't see those things. Hazard ratio is significant. We don't see that all the time. This is the schema. So they started out randomized. I was a part of this study as a contributor, and it was very hard back then to get patients. They were this is not that long ago, but we were recruiting, I think in 2018, we started 2019 approximately, and you had to get the sample and you had to send it to Europe because they had to do the PDL1, and then you had to get it approved, and then once it was, then you had to get the drug, and it's very complex, but it happened, and now these things are a lot easier to get. So a lot of times, this is actually where I want to tell you guys, when you get a tongue biopsy on somebody, we want your pathologist to test the PDL1 right there on that first biopsy, so that when I see them as a make a plan or to facilitate or is that we know that number because we can't move forward with that information. So if you take someone to the OR and so first of all, if you take someone to the OR for a biopsy, right, get a good biopsy, and let's start the ball rolling because it might be an option. But if they come to the second opinion or the process, and then we have to go back and find that sample test, there's like delays, and those delays are pretty significant. So one of the things that I learned is like, if you are taking somebody to the OR for a biopsy, try to get some more information than just that tissue, right? Because the tissue, most of the biopsies can be done in the office now. So get a good sample if you're in the OR so we could do all these extra testing. And then check the exposure, right? Like how are they going to, if they're going to be a transoral candidate, like use that opportunity. Because a lot of times I'm wondering like, I wonder how good it was. I wish I could see. Take a picture, add a lot of pictures into the charts. I mean, all that's very helpful for anybody that's looking at the patient afterwards. It's just a little plug to consider. And so here's the thing. So this is in the guidelines, right? This should be considered for a lot of patients. I'm not saying you have to do this. I'm going to show you some goods and some bads, but it should be considered because we don't have 100% cure rates, right? You don't have anything perfect, so you should be trying to always look for the next option. So if the patient is PDL1 positive, stage 3, stage 4A, and the patient, there's some patient interest there, logistics, and you should really discuss it at tumor board. There's a lot of other factors that have to be considered for patients. And then for certain things like PDL1 negative, are they resectable, autoimmune diseases, very advanced disease. So, and what's the issue? About 1 in 10 patients can progress in that time, but that's what I was just talking to you about, those delays. Like, I think a lot of those progressions are the waiting for insurance, waiting for this. By the time they got into to the tertiary care center up front, all those little delays, next thing you know, you're sitting there like, this was diagnosed 2 months ago, and now I'm talking about getting approval for this. So I think we're still working it out, but there is some issues there. The way to mitigate that is just be check in on your patients. If you have a team, like PA team, whatever you have, like keep in touch. It doesn't hurt if possible. All right, so here's some cases. Young patient. This was I met this patient a few months ago. She's 27, presented with a advanced tongue cancer, squamous cell carcinoma. Any of you who have been in practice for some years have probably come across a young patient with tongue cancer. Everybody gets very scared because you've seen this go a very difficult road over a quick time. And I have seen many. So this woman presented to me, and this was just a couple months ago, and I said, you know what? This is not a small cancer. Like initially it was like, maybe it's a T1, can you just remove it? And right when I examined her, I palpated it, and this was firm. And so I immediately just said, you know what? I called my oncologist, said, I'm gonna make the call. This is T3. We should think of something else. So I there was about a few week delay of that same thing where she had the biopsy, and then we didn't get it. We needed this CPS score. So I just called her, I said, come in, we're gonna do a new biopsy and do that. And that's our new protocol. If you're gonna be considered for this, just get a fresh biopsy right away, unless it's done. So she started. First time she got her immunotherapy, she goes, oh, I feel so much better. All my ear pain is gone. And the oncologist even text messaged me. He said, hey, I think it's working. And so everybody's happy. And then she gets the second dose, and you could see the MyChart messages coming through, like there's issues. And this is what her tongue looks like when I see her into this. And I'm kind of like, wow, this could be something called pseudoprogression, where the immune system fights it so hard that it looks like it's exploding, right? But you don't see that normally until cycle 3 or 2 or 3 or 4. And the only way to know is to keep giving treatment. So it's a very difficult scenario to manage. But she progressed from a T3 to a T4A. Here's the imaging. I'll show you the last one. Nothing going on in the midline that bad. And then this exploded. She's 27. And so then I said, you know what? We're going to surgery anyways. We already had it planned out, but I called her and I said, we're going to have to up the type of surgery. We're going to have to remove some teeth. We already had a free flap possible. I was like, this is definite. I said, you're going to need a G-tube, variety of things. So I took her to the OR. This is what the operation became. So it's like transcervical, right subtotal, a little more than half, glossectomy, right radical tonsil, entire floor of mouth. But we got a very good margin, never had a positive frozen, checking throughout. This is the residual tongue that we preserved. So pretty much the most aggressive what we do as head and neck surgeons, but I actually walked out of the OR, and the first thing I said to the father, I was like, this definitely got worse, but I said, we did the right operation, like for this. Like all the things I counseled them about was needed, and it went as planned, so perfectly. So I felt very good that we got around it, but I was very, inside I was like, I hope this is pseudoprogression. So waiting for the pathology was kind of a challenge. Got her through this, and now she's going to get adjuvant radiation because her final pathology was R0, 1 positive lymph node only, so no chemo. That is, I think from a functional standpoint, going to be good for her, and it's not indicated. But my question was like, could we have found this earlier? And when you look, she actually had this blood biopsy, which I'll explain, where it increased. And so she actually didn't start her immunotherapy to about this timeline. I suspect that the tumor was just progressing while we were waiting, and she's currently just starting her radiation. So this is what do you learn is that not every case is perfect. You got to be on top of this. This is not we view this as surgeons like, hey, you know what? I could be a little more planned. If a patient we're going to do this, I can know in advance exactly what's going to happen and execute better, right? Be more prepared, more planned. It gives me a couple weeks to coordinate the reconstruction. But not just the surgery, could you just detect better? Could we just do a better job at monitoring, detecting? And that's really the key, right? So what is liquid biopsy? Even when I hear that, I'm like, what are they talking about? And what they mean is you basically take a blood sample and you get some information from that, right? So a biomarker is anything you can measure that tells you about a disease. So the most common one that probably all of you have heard of is thyroglobulin. That's our biomarker for thyroid cancer right now. But what is it for all these other cancers? We don't have one. So I think of that's what the tests are. You take a blood draw and they're testing for something. These are the types of tests. So the first one is a HPV circulating fragments. So they basically are testing for a certain set of molecular proteins, and then they find them. You know, that's what they test for. They have a bank. That's what it is. A test for. We use it. Helpful. I'll demonstrate. And then there's this like tumor informed. So they could, take the tumor, test it, and now we're testing for those things that we know are in the tumor. And then there's I'm going to test the blood for tumor factors, but it's just the general panel of 500 or 1,000, whatever it becomes. And that's AI is processing all that, so we can do it all quicker. And those are the types of tests. But why is it helpful? Because there's evidence that you can catch recurrence earlier, way before imaging. For certain things, like an HPV, you might catch it months before any imaging would pick it up, so you know it biochemical. Or in P16 negative, you might catch it by like a year. So now we have these terms, and I want to explain them to you, is like biochemical recurrence, molecular recurrence, imaging recurrence, kind of the way, just like Dr. Candiel was talking about the ways you're testing parathyroid, you're catching it earlier, you're doing this, right? Same type of thing with head and neck cancer. We're catching it in the blood test before we see it in the test, before there's a symptom. And so this is the future is like if you can actively test, you do this intervention, how quickly are the kinetics that we can test that it's effective? Because if it's not, we're going to maybe up the treatment. And if it is, maybe we'll dial down the treatment. Maybe that'll be the future, right? That balance of toxicity and cure. And why? This is recurrence from MD Anderson looking at HPV patients. So if you had a single recurrence, we could treat that, a MET. We could treat that now. Before, when I was just starting, it's like if somebody had recurrence, they were just like waiting to say, or metastasis, is just waiting to say, okay, they got metastasis, we're going to go down drugs now, right? We don't do that anymore. There are recurrences, metastasis that I can take out. My thoracic surgeon can take out. There are things that the drugs work on. There's great things that radiation helps with. So it's not that mentality at all, because you think about the volume of disease, what's going on. It's a different way. We have a lot of options for recurrence and metastasis, and patients become metastatic, and then they respond, and then they become localized again, and then they're back on the table for surgery. So this is a very, it's dynamic. But if you catch it earlier, you might have better options. And here's an interesting thing. This is some of these blood tests I was presenting to you. This is a patient with advanced buccal cancer, free flap resection, maybe like 2 years out. The blood tests went up right here, and they're just slightly positive, right? These are, as the technology gets better, they'll be catching it, the first hint of it in a cell. There's a little hint. This triggered us to get imaging. And on the lump, I think like a T12, something like kind of showed, and then the medical oncologist was like set on this. I'm gonna figure this out. Got the PET scan, got a biopsy. It was positive for a MET. They gave him some systemic therapy, drops down to 0. This is a patient with spine mets that basically caught it early enough, going back on his life with his wife, and now they're very nervous every time we do a blood test, but like they just got cured from a MET, potentially. Here's a patient that I've been treating, probably one of the hardest cases I've had to deal with in the last couple years. Recurrent oral cavity cancer in a very young woman in the maxilla and now we're at palliative surgery was done. But before I did the last surgery, I said, listen, we need something better than just my imaging. So this was her at the third recurrence. We did an orbital exoneration, and then this is after the surgery. So now the imaging is clear, the blood testing is clear. We have a little more hope in a situation that we would just say is we would be giving chemo and all this extra stuff. So we'll see. But it's not always perfect. This is a patient with HPV cancer that only had surgery, dropped to 0. The blood test came positive. This year or two where these tests are low positive is incredibly anxiety provoking for the patients. It is for me as the surgeon, but this went back down to 0, no intervention, a lot of negative tests, probably a lot of money spent on scans. So this is the question, right? Was that worth it? We didn't catch anything. We created a lot of anxiety. We spent a lot of money. And so that's why these tests are not perfect. Everything I've shown you today is not perfect. So the future will hopefully be perfect. So I think I have about a few more minutes. I'll just show you some cases. Larynx cancer. When I was a trainee, I heard about this VA study that was a long time ago, and we were using it for everything. But it was pivotal because it gave an option other than a laryngectomy. Like the idea that you could survive this other than laryngectomy. That's important. Then we have all these other trials, a lot of things happening. And the future is probably, I hope, with some immunotherapy. And this is an example of why. This is a patient, 77. He had pretty severe IgG4 disease and autoimmune conditions. And he had a larynx cancer that was treated with radiation. It was a T2, complete response, looked great. And about 20 months surveillance, his voice was a little off, and I looked and I saw this. I took him to the OR, I biopsied it, confirmed squamous cell. I told him, you need a total laryngectomy. He said, absolutely not. And I didn't blame him because he was actually minimal symptoms. And I said, well, my oncologist and him said, if you're not going to do surgery, you got to do something, and you can't have radiation, we can try immunotherapy. If you don't have airway problems, feel free to try, in my opinion, right? So he tries the immunotherapy, lands in the ICU, cardiomyopathy, like every cardiologist in the hospital seeing him, and basically no major intervention, but has a low EF now. Grade 3, we're done with immunotherapy. Comes into my office, tumor's gone. Never had treatment. And I've been seeing him now for about 1.5 years. You can actually see there was a blip in the molecular testing when that recurrence happened, and then you could see it drop to 0. This here is when he was first diagnosed, like a couple years ago, was doing fine, had a blood testing catch a recurrence, and then they gave him that whole episode, one infusion, gone. This patient, larynx cancer, he already had a trach, he had a G-tube. He was referred in for a laryngectomy. I said, if you're going to get a laryngectomy, talk to my oncologist. We gave him immunotherapy. One treatment. His liver, he goes into liver failure, essentially. And I'm thinking to myself, did I guide him down like another problem, like he's done the surgery. This is him. This is his pathology. He got one treatment, and he had a 40%, the tumor was invading the cartilage, okay? There's no question about this. Final pathology, 40% response, no cartilage invasion, no lymph nodes. And I'm like, that's just, he sat in a chair for like an hour, 2 hours, versus what I would do. It's not a complete response, but there's some impact there. And actually, after tumor board, we said we can't give him immunotherapy. It's too high of a liver risk. But there's still some potential benefit there for him long term. Maybe he won't be that laryngectomy patient that shows up with a MET 4 years or 3 years later. We'll see. Hypopharynx cancer. This is not for immunotherapy. This is about like doing something other than surgery, induction, then radiation. This is a 47-year-old with a really advanced hypopharynx cancer. For this patient, we still worry about recurrence. We still worry about metastasis. But in my mind, when I see her, I'm looking at this test over here too, right? She's very young. So it's a different approach for the same disease that we've been treating for years. If you can't surgerize it better, monitor it better, catch the recurrence better. Maybe these other, and if you can't treat with other drugs. Skin cancer is actually what, skin cancer is kind of what basically caught my attention. Years ago, when we started using it for skin cancer, I deal with a lot of advanced skin cancers. And you know, those patients, their symptoms are out here. They've been watching it, it's growing. So the airway, all these other things never become an issue. So I was always like, try whatever you want. And you just see things melt from one treatment. And you just, that's what I was telling you, it's the power, that immune system power is beyond what we are used to seeing. And like, you know, this woman is like metastatic skin cancer, terrible. March 2021, at that time we were like, yeah, maybe we could try immunotherapy right after the pandemic, right? Still everybody's in their homes. So this lady showed up. She just got, 2 cycles and a couple, you can't, you know, that's with nothing else. And so, these kind of responses you could only make happen. And the summary and take-home point is, we should be doing it better. We're not making these decisions alone. You make them in a team with your patient. There is some real benefit, and I think that you should explore it. And if your practice is not set up to take care of that stuff, there are a lot of people that will, so just make sure it's being considered for your patient. Some of the best referrals I've gotten from my colleagues in otolaryngology is like, hey man, I just wanna make sure we're doing the right thing here. Like we got this, my team, 2 hours away, they're far away. Like, can you just look at everything and make sure we're giving this patient the best treatment? And that's the best thing that we could do for our patients, right? You can't be on top of everything. I can't be on top of all this, but we just gotta know who to get them there, so that hopefully the long-term outcomes will be better. So thank you very much. Thanks to everyone, and thank you.
Thank you, Samer. That was an excellent, excellent talk. Really appreciate it. Fascinating cases as well. We do have a panel, so I guess if people want to stand up, stretch for a couple of seconds, or if you want to leave, go ahead and leave. But we'll go till about 12:30, and then we'll get you guys to lunch. And I know Shant has some announcements as well.
So immediately after this, at 12:30, down in the ballroom, is our second product theater, brought to you by Dupixent. They will be serving lunch on behalf of Regeneron. And so you guys are all invited to go down there at 12:30. Additionally, don't forget the vendors next door. It is intrinsic that they are part of our conference. They give us a lot of sponsorship here, and if there's any products that you guys are interested in, they're going to linger for a little bit longer over there, and then your last opportunity to talk to them will be tomorrow morning at the break. And lastly, right outside here in the courtyard here is a little cantina that was set up so that if you guys wanted, when the pool bar closes at 4 p.m. today, you are more than welcome to go to a cash bar somewhere on the premises here before you guys go to dinner or after you guys go to dinner. It is open to everybody in the college, reps, students, everybody included, that is here supporting our conference today. So you guys, please use that space if you guys want to congregate, have a drink, and normally there should be snacks for that 6-hour period of time as well. All right?
Thank you. Sean? All right. How's everybody doing? We doing okay here? All right, great. Medical students, residents in the room? Awesome, great. Welcome. So a lot of what you're hearing and seeing, these are we've all seen evolution in our practices, and like Dr. Khaderi was saying, is 2 years, 5 years, things change rapidly, and it's all obvious right now that things are changing a lot faster than we all had anticipated in our careers. So anyway, we're going to present a couple of challenging endocrine cases. We're going to try to keep this on time and keep pace. But just to introduce our panel, that's me. That's not AI generated. That's actually an older picture when I was young. No gray hair, but it's the only good picture I have, so I've kept hold of it. In my opinion, it's good for me, but maybe not for others. But anyway, Shant Kogrigian. Shant is a head and neck surgeon, fellowship trained in Indiana, has a really robust head and neck practice, an endocrine practice in suburban Detroit. He's educated residents for his entire career, and he's going to be part of our panel as well. Dr. Kandil and Dr. El-Khaderi, who you've already heard their introductions. The cool thing about this meeting, and we all need to make a special interest, I know every year I get up here and I tell everybody, keep coming to the meeting. It's a great meeting. We have great talks. We have a shared love and passion of otolaryngology. We have the future of otolaryngology in the room as well. And when I come to this meeting, I love meeting other people. And Sam and I were running a little bit late yesterday for our foursome, and we met two awesome guys, Tommy and Kevin, who trained in Botsford, who are now at Jersey and Rochester, and we ended up going to dinner and having fun. So every time I come, I try to meet somebody else and get other perspectives on things. Dr. Khaderi is addicted to golf. He's also addicted to AI. So I asked AI, is he good at golf? So AI says there's no publicly available information suggesting whether Samer El-Khaderi plays golf, let alone whether he's good at it. So Samer, you need to cover your, if your wife Googles this, or ask ChatGPT, you're gonna be in trouble. So what is well documented though is that he's a highly regarded head and neck surgeon, which we know at Rush. So, and then of course, because of the positive bias of AI, so if you're asking in a serious sense, no data, if you're asking in light, inside baseball way, that might be better answered on the back nine with him. So we got to go hit some golf after this. Anyway, the first case we have, a 63-year-old male, longtime smoker, presented to an ENT clinic with dysphonia, progressive dysphonia over several months, no recent weight loss, no dysphagia, otalgia, odonophagia. We're all ENTs in the room. Dr. Candle's ENT by default, essentially. He does more scopes than most otolaryngologists. Anyway, so we do a fiber optic flexible exam. Sammy, why don't you tell me what you see here, Sammy?
See this lesion on the right?
Can you use a microphone, please?
There's a pretty concerning appearing lesion. Seems to be off the right vocal cord primarily. Seems a little bulkier, thicker. Needs a biopsy.
Okay. No secret. So DL biopsy, everybody agree with that? Okay. Any imaging studies that you would get preferentially? Before or after you do a biopsy?
Usually, like something like that, maybe depending what the availability for the scanner and my OR is, whatever's happening first.
Okay. So we get a CT scan. Shant, can you tell me what you see on the scan? Do you see nothing crazy going on right here, right?
Nothing too crazy. I mean, you have your thyroid cartilage is a little bit displaced off a midline. That wouldn't be too scary, depending on the person's positioning in the scanner.
Okay.
But nothing crazy here.
Okay. One thing I want to just point you to is his spine. Does anybody notice anything special about that spine? There's no curvature in that spine. I mean, this spine is rock solid. So it was important knowing this and kind of looking at that spine. When I took him for the DL, his neck was flexed like this, and I was asking anesthesiologist, why don't you guys extend the neck? They're like, it won't. So no manipulation, nothing was going to fix this neck. I tried to move it, adjust it, do anything, but it is rigid. Anyway, now we get a CT scan of the chest. Dr. Kandil, tell us what you see here.
It's a very nice looking left thyroid mass. I mean, possibly a little compression, little deviation of the trachea.
Okay. So we get a DL biopsy. We all agree that that's probably indicated. Anything else, Dr. Kandil? What would you do here, since there's the thyroid involvement as well?
So we depend on the ultrasound. So, I mean, this is definitely meet the criteria for a biopsy. It looks like a solid mass. So there is different guidelines for biopsy, but this will need an FNA in the office.
Anything in particular with the location and the rigidity of the neck? I mean, you see this man, he's like this.
So there's something important though with the guidelines that you always need to do a comprehensive neck ultrasound exam with a workup for the thyroid nodules, because in some cases you can have a sub-centimeter nodule that does not meet the criteria for biopsy because of the size, but you can have a very suspicious lymph node on the side. So I would just always do what we call a comprehensive neck ultrasound from ear to ear to look at lymph nodes. And there are many studies in the thyroid world that showed that the sensitivity of finding suspicious lymph nodes can be more positive than the CAT scan. I had many patients that the CAT scan is red negative, but we find the suspicious lymph node on biopsy and it's metastatic disease.
Any labs? When you see a nodule, do you always get, what are your reflex lab work?
Yeah, it's a very good point. So you want to do a thyroid function test routinely to make sure, for example, it's not hyperfunctional nodule. And it's important to elicit even hypothyroid, so it makes a decision about, let's say it becomes suspicious or something, so then you maybe do a total thyroidectomy. And if you have a patient, for example, with Hashimoto thyroiditis, very well-documented trials, actually in the medical journals, in the internal, in Annals of Internal Medicine, biggest trial from Netherlands that showed that total thyroidectomy in patients with Hashimoto thyroiditis have much better outcome than medical therapy, because by removing the thyroid, decrease the antibodies levels in these patients, so these patients have much better functionality compared to thyroid hormone replacement. So TFTs are important. The other thing that calcitonin is a very controversial topic to check this routinely as in the serum. So the European guidelines recommend for routine calcitonin check because you can rule out medullary. The ATA guidelines cannot recommend for or against. We published a paper that's actually cost effective and it's not going to hurt. So it's a controversial topic in US.
Okay, so we do all those things. The biopsy, no surprise, invasive squamous cell carcinoma. And again, dynamic evaluation of larynx, the vocal folds are mobile. TSH, T4 are normal. The thyroid nodule is FNA'd, benign, but some rare macrophages, some scant cellularity as well. Samra, how would you stage this person? Just, we'll mix in a little head and neck here.
For the head neck,
Yeah, it was the right vocal fold and they're mobile.
T1.
Okay, so you have this patient with a T1 vocal fold squamous cell carcinoma with a concurrent substernal thyroid mass with an FNA. Thoughts? Let's just get your guys' impressions so far. Would you, with the information you have now, what would you do? Would you treat the larynx shunt, or would you go after that goiter? And again, on evaluation, the challenge with this man is he doesn't have a lot of extension for his neck.
So you have a little bit of the order of operations, and I think most people would agree in this room, should be the squamous cell carcinoma and then the thyroid. Unfortunately, you have a person who you may make surgery much more difficult for the thyroid if they are irradiated. So it really depends on what treatment modality you're using for the laryngeal lesion. If it's surgical, which may be very technically difficult because he can't move to begin with, then you could wait to do the thyroid. However, if and my suspicion would be you choose to do radiation, in that case you may make your thyroidectomy much more difficult, and it may not be something you kind of have the appetite for. Either one of these lesions so far, based on the information I'm given, they're pretty. You can sit on either of these for a little bit of time here, and it really depends how fast you can get the patient in the operating room, particularly with the thyroid. But the situation of this particular patient, it kind of usurps that normal order of operations, I think.
Okay, so we presented a tumor board. We kind of hemmed and hawed a little bit about it. In the meantime, the endocrinologist had seen him, unbeknownst to us, had ordered a calcitonin, 10.6, and just for reference, normal calcitonin is 8.4. Samra, anything now? Are you worried a little bit more? Are you thinking this patient may have medullary thyroid carcinoma? And just to give you a historical reference as well, there's no history of family, no thyroid cancer in their family, no history there. And the patient, with regards to the thyroid nodule, says that, "Doc, I've had this for a long time, but we have no documentation of it."
Riz, do we get to see note? Can we see the note? See how it says macrophages, period,
No,
C note?
no, there's
Oh,
nothing else
we
there.
don't- we
I
get
I
no
left
note.
it out. Yeah.
Okay, all right.
Not relevant.
Yeah,
I mean, I think when you treat medullary thyroid cancer, you usually see numbers pretty dramatically higher than that.
How high are you going to see that?
I mean, you see there's some decision making to be made over 300 or 500 about it has implications. So when I see that, it raises another question of, we should probably get this out at some point to rule that out. He doesn't have any other classic features because we got the CT neck. There's no nodes. There's no it's not showing anything aggressive, but it does bring up the question,
Any other labs to see about that calcitonin, Dr. Candiel? I mean, this is barely, elevated, but it's enough to worry our endocrinologist.
So calcitonin can be diagnostic for medullary cancer. If it is over 100, then definitely this is medullary cancer. If it's less than 50, it can be false positive, and there are too many reasons that can cause this. Between 50 and 100 is a very gray zone area where you might push as a suspicious. But one good diagnostic test, as I mentioned earlier, that you can do a washout. So you repeat the biopsy again, and you send it for a calcitonin washout. If the calcitonin is very high, this will be a diagnostic for medullary cancer. If the calcitonin is not high, then this is a benign. And most probably the level is not high here. The biopsy is benign. Then most probably it is benign. So what happens usually for medullary cancer that it can be read as suspicious or atypia, but not benign.
I have a question. So
Yeah.
was the ultrasound FNA pretty easy to do? Because on the scan, I was kind of
Yeah.
wondering how much of it I would feel or see with the
Yeah, it's a good
ultrasound.
question. So an exam, you can't feel anything, and I do in-office ultrasounds and FNAs, but this one, given the location, I sent to IR. And apparently didn't have a problem. So just to kind of go through and conduct a little bit more of a forensic analysis, just to make sure we looked at renal function, et cetera, BU and creatinine were normal. The ratio is 48 of their microalbumin to creatinine, slightly elevated, but not really enough to convince me that, at 10.6, again, we weren't entirely worried, but it did bring up the point. Dr. Candiel, you want to?
Yeah, I just want to add one more thing. So I mentioned earlier the issue of hypothyroidism. So we did a meta-analysis on this. So not everyone after a lobectomy will have hypothyroidism. So that depends on the baseline of the TSH. If your TSH is very low, below 1, there's a very good chance, most probably you will not need to be on a thyroid medication with a thyroid lobectomy. But if your TSH is marginal, like 2 or something, then there is a very good chance you'll be. So that should be taken in consideration. So if the TSH is low, then they are not going to make this patient hypothyroid. So it's very appropriate to push for a lobectomy, and you're done.
Okay. In the same vein as that, what genetic testing, maybe not specific to this, but if you're worried about medullary thyroid carcinoma, what preoperatively, do you do any genetic testing, analysis? What do you guys do if you are suspicious of medullary thyroid carcinoma?
I usually, if I get the diagnosis, then I'll send them to genetics for the BRET.
So that's very good, important. But the problem with the RET mutation that it takes a while. If you do it, the counseling, whatever, it takes a while to get the test. But you can do simply, imagine you have a patient with all this cancer now. What's the issue with the genetic testing? That you want to rule out MEN. So if the patient has a pheochromocytoma, you don't want to take this patient for a biopsy or a procedure, and they stroke on you because the blood pressure is not controlled from the pheochromocytoma. So the key is to rule out pheochromocytoma before. So how do you do that? You do a serum epi or norepi, and that can be diagnostic. So you do not need to wait for this. You don't want to just keep the patient waiting for maybe a couple of months until you get your genetic testing approved and done and all the kind of things.
For that reason, normally, I generally don't bother myself with that. What I do is I make a phone call to the endocrinologist. I get them into endocrinology if I have a suspicion the patient is going to have a medullary thyroid carcinoma immediately. Normally, my endocrinologists are very good about getting people in. Yours might not be. But the reality is getting them into the endocrinologist, letting them work that up a little bit, can make a big difference from your surgical outcome, for sure.
Great. So again, looking at this, let's take there's two paths. Either you're going to start off with radiation therapy, or you could offer TLM surgery for this, and I didn't think that this patient was a good candidate based on my exposure that this patient could undergo TLM procedure, and I didn't feel like I could clear the anterior commissure very well with the limited view that I had. So the plan for the glottic CA was to radiate the patient. How would you guys approach the thyroid here? So the reason I put this slide up is just to kind of give you some anatomical reference. That's the working space that you would have for thyroidectomy. Outside of fracturing his spine, there's no way you're doing a transcervical approach. So, panelists,
So, yeah,
what's
so-
the next step?
I mean, going to the OR, you got to be set up for a partial sternotomy as a possibility. We try, it should be low. I mean, if you do a high volume, your percentage rate should be very low single digits, depending on your referral patterns. But I mean, for this,
But literally, Samar, you are almost cricoid to sternal notch.
So I would
You
just-
would attempt a transcervical approach here, or would you just go straight for sternotomy?
I would, if it's that bad, I would just schedule it that way. I always tell the thoracic surgeon, like, give me a few minutes, give me a shot.
Yeah.
But something like that, if the neck is fused, there's no way. Anatomically, it's just gonna be.
Dr. Candiel?
So I know Rez, you told me many times not talk about ablation, but listen, guys, ablation.
Where are you going to get your needle in from, all right, man? I mean,
No, if you see it in the ultrasound, you can stick a needle in it. If you anything you see in the ultrasound, you can stick a needle in it, and that can shrink. And I honestly think this is sufficient. This is benign. You can shrink this very well, and I'm
right.
sorry.
We'll see you Monday morning. So, all right. So the reason we present this case, because it is somewhat of a potential A, do you have two synchronous tumors, two malignancies? B, how would you approach it from an open perspective? And, you know, this will happen at some point in your career. So I thought it was kind of an interesting case. Next case, and we're doing great on time. We have a 45-year-old female presented with an incidental 2.5 centimeter right thyroid nodule, identified on a CT of the neck as part of a workup for a recent accident. The patient had no compressive symptoms, no family history, nothing else. Again, what kind of workup would you do here? Sean?
So always get a thyroid ultrasound. I want to risk stratify the nodules, and as we mentioned earlier, there is a propensity to pick up things that you don't necessarily always pick up on the CT scan. I always get thyroid function studies as well when we're identifying enlargement or new nodule on a ultrasound, and then or any radiography, and then I would probably pursue a FNA depending on what the risk stratification was.
Okay, so risk stratification, TIRAD scoring recommended a fine needle aspiration. Patient underwent an FNA. It was discovered to be benign. Samar, thoughts? 2.5 centimeters, benign nodule.
I mean, in those situations, if there's asymptomatic, no other features, send her over Dr. Candiel.
But otherwise, you would just monitor this patient potentially if they weren't really interested in
Yeah,
anything,
I
or what
mean-
else would you do? You wouldn't do a lobectomy on this patient, obviously, right?
I mean, not right away.
Okay,
Not anytime
alright.
soon. Definitely
Okay.
wouldn't be pushing for it.
So patient was interested in RFA, underwent a second FNA, and now we're Bethesda 3, atypia.
Can I ask why you got the second FNA? What was the?
So,
I'll let Dr.
it's recommended for the ablation to get 2 biopsies to make sure you are not missing anything and to make sure that you are treating, for example, benign and not a big cancer.
So this was solely in preparation for the RFA.
Correct.
Yeah. There was nothing suspicious on the first FNA. All right. So repeat FNA comes back. But before we go there, how many of you are using molecular testing routinely for your thyroid FNAs? Okay, good. Dr. Candiel, is this a standard? Are we relying, do we have to, I mean, do you recommend everyone now, if you have an indeterminate nodule, the standard of care, or outside the standard of care, whatever you prefer to call it, do you recommend everybody get molecular testing?
So the current guideline, the American Thyroid Association and the NCCN guidelines both recommend routine genetic testing for B3 and B4. And it's actually for things like cancer, malignancy, you can consider doing the gene testing in certain cases to understand how aggressive is the disease and decide on different panels. But it is the standard of care, and I can see it as a potential for, the most common medical lawsuits and stuff like this, medical legal cases in thyroid, it's not because patient had a complication, it's because the lack of indication for surgery. So I do a lot of medical legal stuff, and I can tell you this is a potential for this. If you take a patient because they had atypia and just operate without genetic testing, you did not follow the standard of care and can be considered as a lack of indication or incomplete workup.
All right.
But
How about for
I would say,
yeah, go
if
ahead, Sam.
I would just add to that. So if there's a situation where the patient's like, I want this nodule out, and maybe they're symptomatic, it could still guide your surgery.
If it is symptomatic, there's no question.
Yeah, you
You're
can forego
operating
it,
for
but-
symptoms, there's no question.
But I still like it, because if we're having that partial or total discussion, if this is favorable, maybe that would help us kind of stay away from the
A very good point too. So there are some people say, why we need to do genetic testing if it's a big mass, for example, a 4 or 5 centimeter mass? Why we need to do genetic testing? We're going to take it out anyway. Why need gene testing? Well, let's say it comes back as a BRAF positive mutation. So if it's a BRAF V600E positive mutation, this is double the risk for lymph node metastasis, 5 times increase of extrathyroid extension. This patient will need a total thyroidectomy, a central lymph node dissection. So you approach this patient with one good operation, and you want to make sure there are no lymph nodes, etc. Versus comes back benign, you can do just a simple lobectomy. Also for details for surgery, you go in, you find the thing attached to the nerve. If it's benign, it's okay to leave a little bit on the cord, making sure everything's okay. But if it's cancer, you want to do your best to make sure you clean things, you look for lymph nodes carefully and all this. So it is the standard of care, despite that you're going to operate anyway.
Very good points, and I think I use it especially in that regard as well. I mean, it's more data up front, makes me more reassured intraoperatively when you're unfortunately forced to make a difficult decision sometimes. So the fine needle aspiration comes back after your molecular testing, risk of malignancy of 50%.
So here's the thing, not all the BRAF is BRAF 600B. So BRAF 600B, this means cancer at high risk of all the aggressiveness that I mentioned earlier. And if it has a third mutation, it's associated with worse survival. 50% of patients might not make it after 10 years with a third mutation at BRAF. So that's the difference. But this is BRAF 61K, so risk of malignancy is 50%. Basically, if you do it on benign nodules, you find the same mutation. But also, this is indolent disease that's not progressive. So this patient has this for a while. She's not going to die from this. Maybe she can watch it even as an active surveillance. But it's not aggressive as V600 is. So I'm not telling you that you need to go home and study all the BRAF mutations and stuff like this. The report will give you exactly the risk and all this. So, and these are the standard of care. It just comes, tells you 50%, so you tell the patient this and discuss the options.
So you get a comprehensive neck ultrasound, nothing significant in terms of lymphadenopathy or any other adverse features that you notice there. Where would you guys go with this? Sean, active surveillance, what do you think about that for this patient?
I'm not sure the patient would want active surveillance.
Okay.
I think you gotta highly consider surgery at this point.
Dr. Candile, should I ask you about RFA or no?
I think the best approach for this, I don't do like a paternalistic approach and tell them that's what you need. Everyone is different. Some patients are very protective of their organs. They don't want to do any surgery. They're okay to watch things. The biggest program for active surveillance at Memorial Sloan Kettering, he watched now thousands of patients with cancer. I mean, come on, guys, like, people are not going to die from this, so we know that. So it depends on the patient. Some other patients, they cannot sleep because they have cancer inside them. So you need to really appreciate what they want to do and act accordingly.
Samer, what would you do in terms of a surgery? So the patient wants surgery. What surgery would you offer?
Is a young patient? Is it all 40-something?
50, yeah.
Yeah, I mean, I think in a situation like this, I think I would, as Dr. Kendall said about surveillance as an option, this, that, but if you're gonna do surgery, I'd go into it with a partial approach.
Okay.
I think the one thing everybody says, you know, when you look at high volume surgeons treating thyroid lesions, even the highest volume surgeons have complications with the nerve or patient, as you were saying, with other aspects of the surgery. So I want to go in there, do the surgery, and I would have a very clear goal discussion with the patient. The goal of this surgery is to confirm what is in that thyroid and hopefully rule out any cancer. And then that's how I would approach it.
All right, so patient takes your recommendation, you go to the OR, hemithyroidectomy, 2.5 centimeter follicular variant PTC, no PNI, no LVI, anything terrible on the path.
So I had a similar patient that I had a consult with from Austin, very well-educated patient, who does not want to do surgery. She's like, I don't want to lose my thyroid, it's 50%, I read about all this, I don't want, so you really need to appreciate what the patient wants. She can actually monitor, or listen, she only found this because she had the scan. She has no symptoms, and maybe if she lives somewhere tropical, she would never hear about this, and she can just live the entire life with it without knowing about it. So did this patient really benefit from the operation? I'm not sure.
So what surveillance would you do if she doesn't want any surgery? How often, how frequently
Ultrasounds.
would you monitor her ultrasound?
Every 6 months, and then every year, you want to make sure there's nothing crazy happening, no lymph nodes.
Are we
Thyroglobulin
talking
Samer?
about, so we did the thyroidectomy, and this is what we got?
Yeah.
What, are we talking about more surgery?
Patient elected no more surgery, so we're gonna put her in surveillance pathway.
Yeah, I don't, is it really indicated?
So
The completion really indicated here?
So the guidelines say up to 4 centimeter, which is up to 2 centimeter, you can either do completion or do observation. So if there is no lymphovascular invasion, no extrathyroid extension, no high risk of recurrence, it's absolutely enough to do a lobectomy. But if you counsel the patient and you do a completion thyroidectomy, that's absolutely appropriate option too. So it depends on things. Let's say the patient is already hypothyroid on medication, so it's okay to take it out. So it's all about counseling, and if you decide to do completion, it's absolutely normal. And nothing wrong with that.
I mean, the nice thing is that when I'm in this discussion, I say, well, if we do the completion, then we have a biomarker. So then we could follow you with thyroglobulin. And now the good thing is now I think there's some more information coming up on survivorship. How many years you gotta watch these patients, how long you're gonna do the blood test and the ultrasound. So I think all that,
So how often are you following her? How many ultrasounds are you getting a year?
I mean, I think
You doing annual, you doing
So
every 6 months?
So there's some guidelines now in the 2025 guidelines. One of the newest things that came in there was survivorship. It's very little, but it's in there. That's a start. And so now we're actually having a discussion. I think it's in the range of 5 to 10 years for, depending on the risk and some of the numbers, right? Like ultrasound can happen annually, but now we actually have a turn-off date, which is nice.
Okay, great. All right, we're doing well here on time. Yeah, sorry, do we have a question in the audience here?
I had a question regarding
Yeah.
Dr. Kendall, with your RFAs. How often do you go back and do surgery after an RFA, and what's the percentage of complications after RFA?
So that's a very good question. So there are 2 questions here. So let me answer the second question first. So does RFA increase risk of complications? So RFA is not like a radiation therapy when you cause a lot of inflammation and scar tissue and all this, because it's just a localized treatment inside the nodule. So we actually published a paper a couple of years ago where I remember we had something like 20 patients. We compare them to similar exact patients with similar exact size of nodule, everything. And there's no difference. It does not increase anything. If you go very soon, let's say it's cancer, and you're trying to avoid it and it's not responsive, it doesn't, you see what you can see after a fine needle aspiration biopsy, but does not make the operation more complicated and does not increase risk of any complication. It's not a radiation therapy. So the option of follow-up, you follow up at the standard of care 3 months, 6 months, a year, and then annually, and it depends on what are you treating. So Yeah, benign nodules, if it's less than 4 centimeter or more, the less response compared to the smaller. The cancer also, disappearance rate is almost 99% for a centimeter or less, and it's less with more, and you should not treat more than 2 centimeter.
All right. Our final case, a 74-year-old woman presenting with neck swelling, denising dysphagia, dysphonia. Family noted that she had a weaker voice, and she underwent a flexible laryngoscopy. And you can see, can you all see that video there? Students and residents, your faculty will always say, okay, well, is it weak or not weak? And sometimes it's very subtle and very difficult. And sometimes you have to convince yourself and be unbiased. So a little hypomobility of the vocal fold. This is Samra, Dr. Al-Khadari's case. But we're gonna kind of move along a little bit through this just in the interest of time. Patient, anytime you have hypomobility or paresis, paralysis of vocal fold, people get a scan, right? CT scan of the chest was done and showed a large right thyroid lobe with a 2 by 4 centimeter lesion with possible trachea involvement and an absence of the fat planes. Here you can see some additional cuts prior to surgery. Samra, anything here that you want to highlight? Microphone, please.
The calcifications right away make me think this has been going on for a long time. She came in for neck swelling, like she kept pointing right to her larynx, like out here. So that's that exophytic, hypochic area on the right side, but it was kind of a little tender.
When you see those macrocalcifications, are you assuming papillary thyroid cancer out of the gate?
So actually on CT scan, macrocalcifications don't seem to be as indicative of microcalcifications on ultrasound.
All right. Part of your workup that you performed, an ultrasound described a hypoechoic mass. Fine needle aspiration was consistent with PTC. Your plan was for a total thyroidectomy, bilateral central necks, a lateral neck dissection, possible tracheoesophageal dissection. Which neck were you going to dissect out? The right side, left, both?
The CT actually showed something on the right, and I think at this particular case, the endocrinology thyroidologist was really questioning something on the ultrasound on the other neck, and I couldn't unsee that right vocal cord weakness. Like I saw it subtly, and I just saw the CT scan, and I just couldn't unsee it. So we planned for bilateral, and whenever when you do a lateral, when you do something that bulky, you got to do the central neck as well.
Sean, Imad, yes, no. Do you agree with that plan or no?
Yeah, I tend to agree with that. I'd probably, I'd warn this patient, based on the idea that she might have a vocal cord out. I'd also consent her for a trach and, really talk about that last part, that tracheoesophageal management.
That's a good point, and that brings us to the extent of surgery, right? Airway.
The only thing with the central, though, is the following, that so the definition of central, you should only highlight if it's right, left, or bilateral. And definitely she needs it on the right side where the mass is, and 100%. But to do it on the left, you increase the risk of hypoparathyroidism, which can be most probably these parathyroids will be gone on the right side. So to do it on the left, you really significantly increase the risk of issues with hypoparathyroidism. So unless there is something positive in the ultrasound or something like truly positive in the OR, so it's going to be positive like melanoma, blue lymph nodes, grossly positive, I would shy away from doing the left central on her.
Dr. Kandil, can you describe, there's always a debate of what is a true central neck dissection. What is your central neck dissection?
So trachea to the carotid sheath all the way up to the larynx and down to the subclavian, and you take the thymectomy with you. That's a good central, stripping these nerves, making sure you preserve your parathyroids. Usually good central, you might need to really auto-transplant your inferior parathyroid. It's hard to really preserve it with aggressive central dissection. And for that reason, to do bilateral, you need to have a strong reason for that.
Thank you.
This is medial thyroid cancer. This is a total different disease, total different game.
Sam, what were you thinking about the esophagus?
The way it looked on the scan, I was concerned. This lady, her daughter worked at the same our hospital, so she was a nurse there. So we had a lot of discussion, and like I said, she just came in for some neck swelling. You know, she's 74. She's quality of life is perfect according to her. So I was concerned. I already knew what I was expecting on the nerve. I was worried about how much I can take off the esophagus.
Sean, we always hear about, preserve the nerve if it's working. You get in there, you find this densely adherent mass to the nerve, and your fiber optic scope, you're like, man, this thing's working. But you have the diagnosis of papillary thyroid cancer. Describe to me by shaving the tumor off versus just resecting the tumor. Where, from an oncologic perspective and from a functional perspective, what are you gaining from either or?
So, from a functional perspective,
Have you shaved a nerve and actually had good success?
Yeah, so I mean, I have no rhyme or reason for these patients. Sometimes as anybody doing thyroids in here knows, sometimes you look at the nerve and the next day it doesn't work. I've also, scraped a tumor off of a nerve from, the top of the thyroid cartilage all the way down to the second or third tracheal ring, and the nerve survived and was perfect. I mean, it's very hit or miss. Some of it has to do with the tumor burden. I mean, obviously, if you cannot peel that nerve and have that nerve completely intact, what's the point? So if you have a nerve completely circumferentially engulfed by a tumor, I'm not sure you're really going to be saving a whole lot of function in that case. And doing a reanastomosis, and with the new axon sheath material that is out there, I mean, people have really good results in reinnervation, and that can be done even intraoperatively. So resecting something, resecting a nerve from a tumor that cannot be resected off of the nerve, that needs to be done.
Okay. Thanks. And just kind of speeding along here, Samer, so what did you end up doing?
So there was no way to separate it. I mean, there's mobilizing, but that nodule is fixed. We knew it. I had seen the cord. I talked to them about this something being more aggressive. My limit was the esophagus, so I put a bougie in there, palpated everything perfectly. We actually cut the outer layer, left the inner layer without perforating the esophagus, but I sent final tissue off of that. It did have some positivity on the final path, was microscopic. We're gonna fly through this, right?
Yeah.
Yeah. So T4A, N1B. This is different than the typical thyroid cancers you see on a daily basis. This is either one of those that really went for a long time. So afterwards, we had a decision: can we give her radiation because she meets some criteria by certain organizations to give IMRT. She was 75. We had a lot of debate at tumor board. We said, let's give her RAI. So we treated her with that and then watched her. And like I was telling you earlier, I tend to follow people a little longer. So we kind of watched her, and you see some blip there a couple years later in the thyroglobulin. So we got that uptake scan. Endocrinology, we ordered scans. You go to the next slide. These were like for different things. So we're continuing incomplete biologic response, knowing it's aggressive. We're monitoring her, not just me. I have endocrinologists involved, different scans, don't really see much. You can go to the next slide. That number kind of blips again in 25, so prompts CT imaging. So we've gone almost 6.5 years. She's never complained once, but we identified on imaging now something right in the TE groove. She's 81. And can't really biopsy it because of where it is. And we basically had a tumor board discussion, multiple considerations for systemic treatments like lenvatinib, some of the newer treatments that have been out. There was some concern about tolerance of that and concern for causing a fistula because of it's in the at the mucosal area of the esophagus. So there's a little hesitation about using that. Surgery would require a laryngectomy, so we weren't really offering that as she had no new symptoms. And so we actually went with IMRT, treated the primary site, and this was her planning treatment. There was some other area like under a clavicle that was concerning, so they included that.
Panelists, anything differently? Imad, would you go back in there? 81 years old, high suspicion for recurrence. You have chemical evidence of recurrence. You have some structural evidence of recurrence on your CT scan.
I agree with everything Samer said, except I'm not sure if I want to push really for the IMRT. Even for the chemotherapy, what's indicate chemotherapy, as you mentioned, has a significant side effects, and it's only indicated in documented progressive unresectable disease. Because if it's resectable, ideally you should go ahead and resect it and do not do the chemo. But if it's unresectable and progressive, meaning it's documented to be progressive, you just found it, and the TG is not very high. The TG is only 3 something. It's definitely not metastatic. You worry about metastatic disease if the TG is over 10. So still local, 80 something. Definitely no chemo. I think you were aggressive with the, I mean, I would honestly watch that. These things
Yeah.
are slowly progressive. It took her 6 years for you to find something. Let me repeat this again. If she lives somewhere tropical, she might
So
not
she
wanna
actually,
think
so
about
she actually, the thing is you gotta remember, this is where we kind of resected the whole groove down there. So she started having a little bit of dysphagia. And I think there was a lot of discussion about that, but the treatment with IMRT, when it's done by somebody who treats thyroid cancer, because the truth is IMRT being used on thyroid cancer is pretty infrequent, right? And so when you have someone who understands the dosing, that you can be very contoured. But the bigger problem with this is that we couldn't even get a biopsy of it.
I'm not.
So that's what I was saying. So-
Look, I
so
like
that's why-
you and I like golf, but I'm really saying that we are really torturing our patient in U.S. with too many things. I'm serious, like guys, like in my heart, I've done over 6,000 thyroids and parathyroids. In my heart, I'm not really sure how many patients I really help. Let me put it that way. I'm more excited about what I do right now, really preserving things, 100%. We know that this is far away from metastatic disease. She had a paralyzed cord, so she has symptoms.
She has
got
metastatic disease. But you're palliating her.
metastatic locally.
No, she also had some other things questionable, but it wasn't documented.
I completely doubt it because of the thyroglobulin. If she has no antibodies, thyroglobulin 3, I can't believe that she has anything outside her neck. It has to be something around over 10.
So,
Unless she has TG antibodies, then you cannot trust the thyroglobulin. I did not see the antibodies.
Right.
But if she has the antibodies,
I think that,
even metastatic disease, she's gonna live.
I think this.
hey, guys, I think the audience is getting hangry and my panelists are getting hangry. So, I'm going to put Shant in between these two. But yeah,
I do have one question. So you're showing us this image. Like, are none of these other areas something we can't biopsy?
No, there's the main disease is in that TE group. So the only symptomatic
Okay.
part is the TE group.
Okay.
So the
all
thing
right.
is
Hey guys, thank you so much. Find us at lunch. I'm just going to leave you with a couple of things for some pearls. Be diligent. Conduct a good forensics analysis, right? That was the important thing. Look at your labs. Look at your test. Ask for help. Listen to your patients. For the students and the residents, be persistent, be positive, be productive. My older brother who passed away from glioblastoma always used to tell me that. So work hard, be persistent. Good things will happen for you. Thank you.
Thank you very much, guys.
Sorry to chew into your lunchtime.